Ever open a Med-Surg chapter, see all the bolded terms and feel lost before reading the first line? Key terms are just a small part of the work, but they unlock the rest. If you learn term first, the rest becomes easier to absorb. Everyone thinks a burn ends when the fire stops, but it's not true. The real damage happens hours later, deep inside the surface. Welcome to NurseGetsZen RN Prep. In this video, we'll review the essential burn assessment and treatment terms from Chapter 51 so you can understand what the NCLEX is really testing when it comes to burns. Chapter 51, Coordinating Care for Patients with Burns. First term, actually we have about 30. Allograft, it's a skin graft taken from a cadaver donor. Temporary wound coverage reduces fluid loss and pain until autograft is possible. Autograft, it's a skin graft harvested from the patient's own unburned tissue. So it's actually a permanent wound coverage. It's called the gold standard, no rejection risk. Burn excision, it's a surgical removal of necrotic or dead burn tissue, which prevents infection, promotes healing, prepares a wound bed for grafting. Burn shock, hypovolemic shock due to fluid shifts after a large burn, which is characterized by hypotension, tachycardia, oliguria, requires prompt fluid resuscitation. Compartment syndrome, increased pressure within a muscle compartment, decreased perfusion. So can occur under eschar or deep tissue burns, may require, they call it escharotomy or fasciotomy. Contracture, it's a permanent thinning of skin and underlying tissue after burn healing, which limits joint mobility, prevent by splints, range of motion, and physical therapy. Cultured epithelial autograft is a large grown epidermis from a patient's own cells. Using massive burns like greater than 70%, when donor skin is limited, which is fragile, but also it's costly. Debridement, it's a removal of necrotic tissue or debris from wound, which promotes healing and reduce infection risk, so can be mechanical, enzymatic, or surgical. Deep partial thickness burn, it's destruction of epidermis and deep dermis. Red, blistered, painful, may appear waxy, which means may require grafting, heal slowly, and at risk for scarring. Donor site, it's unburned area where autograft skin is harvested. Actually heals in about 7 to 14 days, may be reused for future graft. Next one, eschar, hard, leathery necrotic tissue from full thickness burns. which must be removed to allow healing and perfusion. Eschartomy, it's a surgical incision through eschar to relieve pressure. I said earlier. So restores circulation and ventilation in circumferential burns, and I said that at the compartment syndrome here. Fasciotomy, incision through fascia into muscle, used in electrical burns or severe compartment syndrome to restore perfusion. Now we go a little bit down. We have full thickness burn, involves all skin layers, epidermis, dermis, and subcutaneous. So skin white or sharded, non-bleaching, insensate, requires grafting. Hydrotherapy, it's use of water to cleanse burn wounds during dressing changes. So aids debridement and comfort to prevent infection. Lund and Broader chart. It's a detailed tool for estimating the percentage of the tissue burned according for age and body proportion. So it's the most accurate burn surface estimation. So this is very important in the quizzes, exams, and NCLEX. When it's about burns, you need to remember this tool, London Burn chart. Meshed graft, autograft with holes allowing expansion. So it's like 1 to 1.5 to 1 to 4 ratio. So it covers large areas. It's less cosmetic, but maximizes limited donor tissue. Myoglobinuria. It's a myoglobin in urine from muscle breakdown, especially in electrical burns. May cause acute kidney injury. Maintain about 1 ml per kilogram per hour. So 9 of rules, we know this quick estimation tool for the total burn surface. It's used in the emergency setting for initial fluid calculation. And, rule of nines, rule of palm is the patient palm, about 1%. Useful for small scattered burns or pediatric cases. The sheet graft, it's a solid, unmenshed autograft, so no holes. Used for face, hands, and best cosmetic outcome. Split thickness skin graft. It's a graft containing epidermis and part of dermis. Heals donor side faster. Most common graft type. So this is the most common graft type. Split thickness skin graft. Superficial burn involves only epidermis, so it's like sunburn. So it's like red, dry, painful. Heals in about 3 to 5 days without scar. Superficial partial thickness burn involves epidermis, apodermis, moist, blister, bleaching. So this heals in about 7 to 14 days with minimal scar. Systemic inflammatory, it's a widespread inflammatory state due to tissue injury, so may progress to sepsis for if it's untreated. Total body surface (TBSA) is the percentage of body surface involved in burn injury. So determines the fluid need, severity, and transfer to burn center. Xenograft, it's a temporary skin graft from another species like pea cow fish, used when allograft it's unavailable, so it's a temporary coverage. Go a little bit more lower, and we're almost there. Zone of coagulation. It's a central area of irreversible tissue necrosis, immediate cell death, deepest injury zone, zone of stasis. It surrounds coagulation zone, decreased perfusion, potentially salvageable. So it's a critical target for resuscitation to prevent burn wound conversion. The last one, zone of hyperemia, outermost zone with vasodilatation and minimal injury. So this usually recovers fully with adequate care. Now let's go and let's recap a little bit. So let's recap. Everyone thinks a burn ends when the fire stops, but that's not true. The real damage happens hours later, deep inside the surface. The real burn happens hours later after the flames as fluids shifts, tissues swell, and perfusion drops. Recognizing those changes early is what saves skin, prevents shock, and protects your patient life. So now you know the real burn doesn't end when the flames go out. It continues inside the body as fluid shift, inflammation, and tissue hypoperfusion. What we can call burn shock and the zones of injuries. That's why early assessment, fluid resuscitation, and debridement are crucial, preventing tissue loss in the zone of stasis and saving valuable skin. And when real when healing begins, autograft, allograft, and careful wound management restore both protection and function. So in short, what happens after the fire determines whether your patient recovers or decline. That's the difference between just memorizing terms and thinking like a nurse. Thank you and see you next time. Bye for now.